Good evening, happy Wednesday, and welcome back to Health Plus Weekly. I am Dr. John Podkowa. I'm joined by our nurse practitioner, Hannah Raymond, our media specialist, not doctor, but Peter Kohana, and we are...
Honorary doctor.
Yes. He's certainly earning his way towards a medical education, answering questions that come in via Facebook. He's done a great job. So welcome back. We are excited for tonight's show. We are opening up the show tonight. We do not have a guest. Actually, our guest will be you guys who are watching. We would like to welcome everyone to send in questions regarding general medical questions that you have that Hannah and I will try to answer for you tonight. For basically all topics, I would say excluding pediatric questions, as we don't take care of children. So via Facebook or the anonymous line our producer Josh puts up on the screen, please feel free to send those in because they'll be a big part of the show tonight. We've also prepared, Hannah researched kind of, just to kind of jumpstart the conversation, the probably top 10 to 15 reasons why people seek out primary care and kind of what those diagnoses are. And we'll walk through those to maybe answer some questions you may have. And also the most frequent types of medications that we prescribe in the primary care setting, and maybe just talk about some questions and comments regarding those that people have. Right. So
we can start by talking about kind of the scope of the types of visits that we're talking about. So the latest data that I could find was outlined about 990 million office visits annually in the United States, including specialists, your primary care, some type of outpatient hospital visits, and about 50% of those visits were to primary care providers, so that would be like our practice. So some of the most common complaints so there were kind of two different areas. It was what people came in with, and then kind of what the top diagnoses were. And so just to kind of jump right into it, and I think that we find this very true in our practice, were joint disorders. Kind of one of the biggest complaints that we see consistently throughout the year are joint disorders. So what are some of the common things that you see people come in with?
So people come in, and whether they're complaining of their hands hurt, their wrists hurt, their shoulders hurt, their hips hurt, their knees hurt, and it's really like all different ages. It's young people in their 20s, it's people in middle age, 40 to 60s, and then it's kind of the geriatric population. And what they're worried about and what they come in, they're confused about whether this is arthritis, if it's, they worry about is it rheumatoid arthritis, and how can, what caused it and what can make it feel better. So I guess starting with just the most common causes of really joint pain, I think would be osteoarthritis, which for a lot of people we have, spaces in between all our joints that allow our joints to move and kind of, work without friction. And as we age, that space, wears away. And there's cartilage between some joints that begins to shrink as well. And there's a hereditary component to it, but even if you don't have a family history of osteoarthritis, you can have it. And those typical pains are in the fingers, in the hands, hips and shoulders.
Knees.
Yeah. Classically, that pain is worse at the end of the day, which is kind of a delineating factor. We talk about people if it gets worse while walking, or if you're on your feet all day, that leads more towards a diagnosis of osteoarthritis.
And then the other kind of thing that we try to delineate between osteoarthritis and then there are inflammatory arthritises as well, which are more of your body is kind of attacking the joints in its own way. And one of the delineating factors between that and osteoarthritis is that oftentimes you're stiffer in the morning, and then as you get up and move throughout the day, your pain gets better. So that, kind of when you're thinking about, your aches and pains and going to see a healthcare, provider, that might be a good thing to be able to identify there too. Other kind of factors are, is there any swelling? Is there any redness? Is there any warmth? Which can kind of be present in both, but, important to talk about as well.
Does weather really play a part in joint pain? I know you
Absolutely.
You hear that. That's true?
Yes.
Yeah. Like today.
Yeah.
People are achy today.
Yeah, and because the joint spaces are kind of pressurized because there's fluid and there's as kind of barometric pressure. Yeah, so I think there's a real correlation to people say about that as well. And a lot of the time, based on what people say, we can help in kind of looking at them, just examining their joints. We can make the diagnosis. Oftentimes, with osteoarthritis, a simple X-ray, which is low risk. There's not a lot of radiation. It's really inexpensive. At our facility at Southcoast, we have it right on premise, and so do a lot of other sites. And so it's not a real hard diagnosis to make.
Right. And that actually shows the thinning of the joint spaces and if there's any kind of bone-on-bone contact that might be causing the pain. So that's what we're looking for there. And then what do we do about it?
Yeah. So a variety of things, starting from sometimes just stretching or over-the-counter medications like ibuprofen or Aleve, which you've heard of, or Motrin. Some certain supplements like glucosamine, some people may have heard, are really effective. And this is regarding osteoarthritis and also perhaps some inflammatory arthritises. As they get more serious, we have several doctors that we work with we were really fortunate to use. So doctors called rheumatologists are physicians who specialize in joint pains and can help us in terms of sometimes they do joint injections, sometimes there are special therapies that they can give, like you may have seen on television, Phil Nicholson advertises like these biologic agents. And then we have a great team of orthopedic surgeons and their specialists who, if it's severe enough, can either, there are some operations, there are joint replacements. And at Southcoast we have the, kind of a full range. And I'm embarrassed I neglected to mention physical therapy, who we've had on the show too, who are kind of intermediary between, going for surgery and who are a great option.
And another thing I know that we talk about a lot is the role of weight loss and kind of alleviating the pain that can be exerted on your joints. So if people are complaining of knee pain or hip pain or foot pain, just think about the amount of weight that you're carrying around as exerting pressure on those joints, as well as kind of gravity and the natural aging process as well.
Question from Cheryl in line with this conversation. Her husband, she's concerned with her husband's knees. He recently started to play, or he's concerned with his knees, excuse me. He recently started to play basketball with the men's group after work, and his knees have been really sore when walking afterward.
So that very common, especially if he's just restarted kind of activity of that level again. That would be probably more towards an osteoarthritis, where if you're not sore at the beginning of the day, but you're sore after activity, that kind of points more towards that diagnosis.
It could also be a tendinitis as you're starting to get physically active. So tendons connect our muscles to bones, and they can get inflamed. And anything with itis just means inflammation. So that's a pretty common, after without kind of looking and seeing them. But if you haven't used those muscles in a while and you start, especially a high impact stop sport like basketball, so.
Any tips for what he could do beforehand that might help kind of alleviate the pain afterwards, or afterwards, icing, anything like that, stretching beforehand? What are some tips?
Yep, so certainly stretching beforehand and kind of gently warming up as well is important to kind of loosen everything up and warm up all the tendons to prevent against a tear or a rupture. And then afterwards, and sometimes even during the activity, even soft knee braces I find are helpful, just to kind of add a little bit of stability to the joints, and are relatively inexpensive. And then afterwards, kind of thinking about if there is any inflammation that occurs, you would want to ice it. I generally try to tell people not to, stop moving entirely, because that tends to kind of backtrack things, but just kind of gentle range of motion and gentle stretching. And combined with some of the anti-inflammatory over-the-counter medications, like Dr. Podkowa mentioned.
We get a lot of questions regarding heat or ice. I often recommend ice. It calms down the inflammation. It helps decrease some of the blood flow. It doesn't feel as great, but I think ice is really effective. And kind of all the same things Hannah said.
And kind of thinking about basketball and common injuries in basketball as well. If there was any kind of the other things that we look at in evaluating knees especially are joint instability. So if you're walking and your knee buckles or it clicks or kind of gives out in you, that may be indicating that there is some type of ligament injury as well. And you might, again, it might not mean surgery, it might just mean physical therapy and some rehab.
That's a great point. Knee complaints, very common. So what's going on in the knee? There are muscles, there are ligaments that kind of hold the knee in place from slipping side to side and going back and forth. There's a meniscus, like Hannah mentioned, in the middle. So, worrisome signs are things if the knee is clicking or locking or getting stuck, like you mentioned, or if it feels like it's not reliably underneath you, like you mentioned. That's a sign that to get checked out sooner rather than later, because there could be something a bit more serious than going on than a typical inflammation or a little bit of arthritis.
What's next? What's the next most
on
our list of common primary care complaints?
High blood pressure, we see a lot of people for. They often don't complain necessarily that they have high blood pressure or coming in. They may complain of headaches, they may complain of some vision changes, but I think most oftentimes they come in whether their blood pressure is high somewhere else or they have questions about what does it mean to have blood pressure. Do I need to still continue on medications? If I get put on a medication, do I have to take it forever? I'm not sure. Does that ring a bell with you? What people see you for?
Absolutely, yeah. I mean, we talked kind of before about presenting symptoms that people may complain of for kind of these common primary care issues, and high blood pressure is, commonly referred to as one of the silent killers or silent diseases, because you may not have any symptoms at all, which is why it can go so long untreated and cause damage almost before it's too late to be treated. Because you may not have any symptoms at all, and oftentimes people don't really feel any different after their blood pressure's better controlled than they did when it was not as well controlled.
Why we worry about blood pressure, it is perhaps the leading cause of death in the world, or preventable cause of death in the world. The increase in pressure, it raises our risk for stroke, heart disease, eye damage, kidney disease as well. So super important to know if you have high blood pressure. When Dr. Michael Rocha was on the show talking about it is a disease that does not have a lot of symptoms, so going to, whether it's your doctor, your primary care doctor, or the supermarket, American Red Cross, the New Bedford Wellness Initiative, all throughout town has these blood pressure screening checks. Really important to find out what your blood pressure is, because many of us may not know that we have high blood pressure.
And it's funny that you bring up Dr. Michael Rocha, because he is asking us to remind people today is National Walking Day, and his wellness walks that he does are coming up this month. And Dr. Rocha, if you want to just put in the comment section when and where that is, we'll let people know. And then we've also got the $1 million question that we seem to get every week. Are you accepting new patients?
At the moment, my practice is currently closed. Unfortunately, I'm very lucky to have a full panel of patients. But we can at the end of the show talk about what doctors are accepting and how we can direct. So regarding blood pressure, I think one of the questions that people ask and worry about, which I think is a good thing to have a healthy worry of medications and how long you'll be on them, is will I have to stay on them forever? And the answer is not necessarily, it's not straightforward, but maybe not, depending on there are a host of things that may cause your blood pressure. We can talk about whether it's diet. There's a tremendous link between a high salt diet and blood pressure. Being overweight, smoking, excessive alcohol use actually raises blood pressure. Sleep apnea, we had Dr. Mello on talking about if you have sleep apnea and you don't know if you're raising your blood pressure. And
even poor quality sleep, I was just reading recently. So when somebody presents to us with high blood pressure, kind of the first thing that we look at is how high is it? And is it causing any kind of worrisome neurologic symptoms or any chest pain symptoms that might be a little bit more emergent? But in the absence of any of those kind of alarming symptoms, we can then take the time to, and I oftentimes, depending on how high it is, will kind of offer people the chance to bring it down naturally, kind of with those lifestyle changes that you mentioned. So going over those is a high salt diet, kind of a general rule of thumb that I like to tell people is a less than 2 grams of sodium, and that's from all sources, added, what you're buying in the prepared foods that you have, less than 2 grams of sodium a day. Certainly kind of decreasing the alcohol intake, so we now know that less than 2 drinks a day for men and less than 2 drinks a day for women is probably best. Certainly not smoking. And then regular physical activity are kind of and getting good sleep are the things that we can control in terms of controlling blood pressure.
One of the most important, I wouldn't say most important, but one of the best articles I've read, and I try to remind people regarding this, is really well known that foods rich in sodium raise blood pressure. Foods rich in potassium actually lower blood pressure. So, kind of Google and get a good list. I have in the office, foods rich in potassium. The irony is that most processed foods, in order to make them last longer on the shelves, are stripped of potassium and loaded with sodium. So it's this counterintuitive thing that happens. So, and if you were like me and are not good at reading labels, typically foods high in sodium, anything in a box, bag, can, or bottles is not great. There's often a lot of sodium in it. So just to be careful with that.
But as a caveat to that as well, some of the high potassium diets aren't great if you do already have kidney disease. So just to be careful with that as well.
And then treatment for high blood pressure, if we do often recommend in our practice, a trial of changing your diet, changing some modifiable risk factors, and then coming back and being reevaluated. We typically make the diagnosis of high blood pressure, not the first time because people are nervous, but usually 3 different readings on separate days to make the diagnosis. But if at the time, we think medications are appropriate because it just will lower your risk, there are a number of medications that have been around for a really long time that are exceptionally safe and have really good evidence and lots of different studies and trials that people feel fine on. You know what I mean? They whether it's a diuretic or a water pill, which takes some extra fluid out of your system, whether it's medications that work on your kidneys to help kind of modulate the way your body manages the pressure in your body, whether it's in the heart. We try to take advantage of, if you have anything else going on in your body, to maximize as little medication as possible to get the most effect.
While we're on the subject of diet, 2 questions on apple cider vinegar, one from Kim and then a follow-up from Bethany. Just wondering about, just kind of your opinion on the efficacy of apple cider vinegar as...
For...
It doesn't say specifically what for.
I tell you, this is where I recommend apple cider vinegar. Believe it or not, is for nail fungus, is for people who have toenail infections. It's pretty effective as kind of an anecdotal treatment for some nail funguses under the counter. For sunburns, it's been pretty effective for some of my people. Some of our patients. I haven't seen it with blood pressure or cholesterol, but...
So I haven't, just kind of anecdotally as well, people in the office have mentioned just kind of overall feeling a bit better, taking, I think it's about a tablespoon or so of, and I'm not sure if it's a particular type of apple cider vinegar, kind of just feeling a bit more regulated in terms of their bowels. Sometimes people have told me that their skin is clearer. But I don't know I haven't seen any studies. Maybe they are out there. We'll have to kind of follow up on that as well, to see if we can find any data on, apple cider vinegar specifically for blood pressure, really any other, benefits. But kind of, is it harmful? And I don't think so.
Any other questions in the queue?
Nope, we're all caught up.
Good. Next on our list of common things that we see in the office, Hannah?
So we have spinal disorders, which the first thing that comes to my mind is low back pain.
Sure, yeah.
Which is what we see, particularly, all year round. So when somebody comes into you with low back pain, what's your progression of questions? What do you usually ask people?
So people come in and first of all, it's very common. Over 70% of us at some point in our adult life will have low back pain. And there are a variety of things that can cause it, whether it's the muscles strain, whether it's nerve inflammation, whether it's a bulging disc, whether it's a broken bone. And then there are some other real serious things that we worry about that can cause back pain. So I think the first thing that we do is try to tease out right away if there's something worrisome going on with the back pain. Overwhelming majority of back pain is not being driven by something real serious, and so we can manage those, not in a rush and take our time. But there are some things you want to pick up right away and you should be aware of. So the things that we worry about is, one, is it an infection driving the back pain?
So fever, chills, yes. Any warm kind of bulging area?
If you've had a recent procedure done recently or an operation, or if you had a history of IV drug abuse, or if, coupled with fevers, chills, excruciating pain that is actually worse when you're lying down, that's worrisome. And if you have a joint replacement or a prosthetic joint in your body that that raises a flag, and we do more questions about that. Cancer can go to bones and cause back pain and can cause bone pain. So certainly anyone who has a current diagnosis of cancer or a past history of cancer, we just take it a little bit more seriously when we ask questions about it. Certain cancers are more likely to go to bone, prostate cancer in men, breast cancer in women. There are certain primary bone cancers. So if you have, kind of a history of active cancer or cancer in the past, we ask questions. Something concerning about that, again, is pain at night, pain that doesn't get better when you're laying down.
Pain that wakes you from sleep is always...
Pain that wakes you from sleep is a little bit concerning with that. Absolutely. Other things we worry about is if there is a real serious bulging disc that is compromising the nerves for people. That is, really emergent, because that can escalate quickly. Symptoms of that are, again, really excruciating pain. If you lose the ability to hold your urine or your stool, and you're just having accidents, or if you have this numbness sensation in your groin, almost like what we call saddle numbness, that's worrisome. And it's actually a neurosurgical emergency. We get people intervened on right away. Also, if you have a really massive deficit in strength in your leg or kind of lower extremity where you're dragging it, foot has dropped, we escalate those right away.
So in the absence, that's kind of the initial assessment when it comes to low back pain, and so from there we can kind of be a little bit more conservative in the treatment and also the diagnosis too. So generally, the question that I'm asked pretty frequently is, do I need an MRI? And when do I need an MRI? So in the absence of any of those really alarming symptoms, my understanding is that the treatment, whether you have a bulging disc or a muscle strain or if there's any, in the absence of also an injury that may have caused a broken bone too, the treatment is the same initially. So we generally recommend, again, the over-the-counter ibuprofen or Tylenol. Sometimes there is a role for steroids. There's a little bit more data in the cervical spine than there is for low back pain in terms of decreasing inflammation there. But again, just gentle stretching, core exercising, perhaps a chiropractor, perhaps some physical therapy for a good 6 to 12 weeks.
Which is forever if you have back pain.
Which is forever.
I'm not sure if,
yes.
if you, but we try to, I think we reassure patients that this is going to get better. Because people are worried they're going to have this forever,
Mom, I know you're watching, so you heard it from the doctor.
In most, overwhelming majority of back pain gets better, which is good. And, again, like Hannah said, 6 to 12 weeks, a lot of it, subsides, with conservative treatment, which is great.
Right. Within that time frame, though, I certainly always reiterate those alarming symptoms that should anytime during that physical therapy or your stretching or anything, should you develop any of those alarming symptoms to call us again.
Super common question is should I just lay down, bed rest? And actually the answer is no. You want to try to stay as, kind of objects in motion stay in motion. So we don't want to be rocky. No pain, no gain is not the answer. Right. But we want to kind of stay moving because that will help with flexibility and mobility, through the treatment.
And in terms of prevention, kind of moving forward to prevent, another low back injury, kind of people don't think about it, but your core is really important in stabilizing your back as well. So kind of strengthening the whole midsection, front and back, is really important moving forward too.
Yeah.
So.
Got a couple questions in the queue here, a little off subject of what we're talking about, but good ones. From Debbie, what can you take for a chronic cough?
Debbie, great question. And that is perhaps one of top 3 most common things we see in the primary care office. So thank you. I guess it depends on, which Hannah and I will say, was what's causing the cough. So common things that cause coughs that last, that don't go away. Smoking. So number 1, so people who are smokers need to stop. It just disrupts airway. It kills these little hairs that we have in our lungs that help kind of brush out debris, and it makes them less sensitive, and it irritates the bronchioles. Behind that, some medications, believe it or not, that people are on. So it's good to actually, if you're on medications, certain blood pressure medications can make people cough. They're what's called the ACE inhibitor family. So any like lisinopril, enalapril, quinapril, benzapril. These medications are notorious for
a dry cough,
a dry, tickly kind of cough. Not so common things that make people cough are postnasal drip, so allergy season or something's going on there. That's often kind of like, a little bit of
throat
a
clearing
type cough. And acid reflux is a really common cause of coughing that kind of goes under the radar, might be causing it.
And maybe worse at night too.
Yep.
Sometimes.
And there could be some throat clearing with it as well.
Mm-hmm. Other causes of cough, a chronic anything is worth getting checked out, especially a cough, and especially if you have a history of smoking or a family history of lung cancer too, because any type of protracted cough does raise the concern. For an underlying malignancy as well. So any, if lung cancer could be a possibility, that would be something that you'd want to get looked at as well.
So if we saw people with a cough, come in, if they, whether or not they're smoking or not, it kind of lowers your threshold to get a chest X-ray, depending on it, which is a simple test, low radiation. And then if someone's not smoking, if someone's not on a certain type of blood pressure medication, if the X-ray is fine, then I usually go down one route or another at one time. So I'll either start with a nasal steroid spray, like Flonase is over the counter now. You can try that, really effective. That treats the upper airway cough syndrome or postnasal drip, and works pretty effective. And we tell them if that doesn't work, try that for 4 weeks or so. If not, then an antacid medication like a Zantac, Pepcid. Really effective.
Over the counter also.
Over the counter also, you can try as well. And either way, and those, and we get a lot of bang for our buck in terms of those treatment modalities.
The other thing we should mention with cough is certainly the underlying chronic lung disease as well. So if you have asthma that is untreated or poorly controlled, that can kind of present as a kind of a dry, tight cough, or COPD or emphysema. Sometimes can also be a cough, and maybe a sign that you need to get on a little bit better control for both of those types of lung disease.
So what I'm hearing is there's some options for Debbie, but if Debbie hasn't been checked recently for this, and first step should probably be to go see her primary care doctor and just make sure that there's no serious underlying issue going on.
I think so. If you've had a cough for more than 3 or 4 weeks and you're over the age of 40, depending whether or not you've ever had a smoking history, we would strongly recommend a chest X-ray to start, and then you can go from there. Yep.
Next question is from Maura. She wants to know how you feel about HGH. Is it safe to just start taking without checking with a doctor? I have a feeling I know your answer on that one, but go ahead.
So I'm not familiar enough with it, whether you could get it. I assume you'd be getting it over the counter or maybe on the internet or something. I would, as not knowing enough about it, I would say no for my personal comfort level.
Yeah, thank you, Mara. Good question. I don't know enough about it to talk about it, but it actually leads to just something we wanted to say in the show tonight is, as we are planning our future calendar for shows, if there are topics or things you'd like us to address and bring guests on, please take the time to send it in and write to us, because we will try to get people in. We have talked about we've had nutritionists on the show, but also kind of alternative medicine supplements is a whole different show we could do on ourselves, and we could certainly circle back to this. So whether it's this topic or others, if you let people, people who are watching right now, think about what you'd like to hear, guests you'd like us to try to invite on, or if you know someone who wants to write into the show, as we're planning our calendar, we want to try to get people to you that you're interested in seeing.
So you can leave it in the comments section, certainly, or is there another better way that you would recommend?
No, comment section would be great, yeah. I think we certainly monitor, and if we see those, some commonly suggested themes, I think we'd be happy to get the specialists here who can talk about it.
And then kind of closing out on back. So when an MRI is appropriate is if symptoms are not improving, passing kind of an 8 to 12 week threshold. If your reflexes, foot drop like we talked about, and then if we do discover that you have a bulging disc, it's putting pressure on a nerve, or there's severe arthritis. There are a number of things that can cause it that are can be picked up on MRI. That doesn't necessarily mean you need surgery either. Sometimes those get better on their own, again with conservative therapy. But we also have a great brain and spine center program at Southcoast that has physical therapists, physician assistants, neurosurgeons, pain management specialists to help our patients get through that, which is great. So there are a lot of options, everything from conservative to certain surgeries, and there's again, there's hope for people with back pain. We have a lot to offer.
And that program is led by Dr. Matthew Phillips, who is a New Bedford born and raised. So yeah, get treated by. You might see him down at the docks fishing.
Yep.
He spends a lot of time down there, but he is a local guy to take care of you. And just Tracy is again asking about your availability for patients. We talked about this a little bit earlier, Tracy. Dr. Podkowa is not currently accepting new patients, but we're going to talk a little bit at the end of the show about some doctors that he would suggest you looking into. And then we have another question here from Jeanette. What are you? Oh, you're gonna have to read this one. This is a science word.
You can do it.
This is a science word in it. What are your thoughts on PRALUENT and those types of cholesterol lowering medication?
So those are the newer classes of medications.
Yes.
PCSK9 inhibitors, and I had to look that up. I didn't know that. And I'm not super familiar with their use. I know that I don't prescribe them in primary care. I don't know if you have any.
I have not prescribed them yet. I think that they are a good option for people who cannot tolerate first-line, cholesterol-lowering medications like we use which have been around for longer, that we primarily use in our clinic, like the Lipitors and the Zocors, which because there are a subset of people who do not tolerate them well for a variety of reasons, and up until recently there wasn't a good option for lowering the cholesterol. So for people who fall into that category, whether it be an endocrinologist who we have at Southcoast or a cardiologist who are prescribing those medications.
So we can kind of segue into talking about high cholesterol as another common thing that we see in primary care.
Yeah.
Not next on the list, but certainly definitely on the list of top. Not people don't necessarily come in complaining of it, but we tend to treat it pretty frequently. So usually, how do you discover that somebody has high cholesterol, and what does that mean?
People ask about it. People are, I think, for the most part, kind of aware of high cholesterol and its linked to heart disease, and so many people would like to have their cholesterol checked. I think, and so we talk about it in terms of depending on your age. So current guidelines for adults, just so you know, are unless you have any major risk factors, usually around men, 35, you start screening for high cholesterol, and then depending on what the results are, it can be every year after that or every 3 to 5 years. Women are actually because of the benefits of hormones that they have an advantage. They start screening at 45 for women for checking for high cholesterol, unless you are significantly overweight, have a real bad family history of high cholesterol, or are diabetic, or for some other reasons. And people have questions about what is cholesterol, why do we worry about it? Our body essentially needs cholesterol to, this is the way I explain it, build things, because our body has to be built, as it's developed. And there is good cholesterol that helps kind of build certain parts of the body. But then unfortunately there's also, when we get too much cholesterol, mostly because of our diet, sometimes there's a hereditary component, it starts building things in the places that we shouldn't be building. Bridges get laid down in roads that shouldn't be blocked. And they lay down what's called plaque in our arteries, and those arteries around the heart and in the brain, if you get too much plaque, it can cut off the circulation, which delivers oxygen to tissues and can lead to strokes and heart attacks. And also the problem with the plaques is they're not stable, they're not built well, and so sometimes they break off and can cause traumatic changes quickly, and which that causes sudden heart attacks or a sudden stroke, and that's why we worry about cholesterol. So again, another disease that is not symptomatic for the most part.
Right. We tend to do a pretty good job screening for it, though. And so when somebody have had a screening test, a blood test done for a lipid profile, it's a fasting blood test because, if you've eaten or drank anything that does contain fat in it, it can affect the readings. So we generally like to discuss the results with people kind of in person sometimes, and again, just with same with high blood pressure, depending on how high the total cholesterol is and kind of the different components of the lipid panel. Again, giving people a chance through those lifestyle changes. Many of them are the same as lowering blood pressure to kind of bring those numbers down naturally.
And lots of questions about what type of cholesterol it is. There's good cholesterol, there's bad cholesterol. What does that mean? So when you get a traditional cholesterol panel, there are more advanced ones, but the ones we look at, they have total cholesterol, which is a combination of all the different types of cholesterol in your body. Usually we like that number below 200 for just kind of general speaking purposes. Then there's something called HDL, or high density lipoprotein. And I always tell people, remember H for healthy. So the H is the good cholesterol. That cholesterol kind of goes out into your body, removes bad cholesterol, brings it back to your liver where cholesterol is made, and repurposes it for good purposes. And people who have high HDL, greater than 45, 50, 60, 70, 80, it's really protective of their heart.
Yep.
And it's indicative of a really good healthy lifestyle. So people want to know, how do I get it up? Well, there's no shortcut to that. It's eating well, it's exercising, there's a bit of an hereditary component.
And it tends to be higher in females naturally than men as well.
But it lowers your risk for heart disease, which is an important thing to know. So when you're looking at your cholesterol numbers, H for healthy, remember that. LDL, or I say L for lousy, is the cholesterol that is not so good. So L for lousy. You go through medical school or you learn lots of mnemonics to remember and trigger certain things. That's the one that's a problem. And depending on your age and risk factors, we want that below certain numbers.
So general population, kind of the guidelines changed not too long ago, but 130 is good for some people. Less than 100 is good for other people. And if you do have, diabetes or known heart disease already, in terms of if you've had a heart attack or if you've had demonstrated, coronary artery disease, less than 70 sometimes is better for the LDL cholesterol. And then there's triglycerides as well, which can actually, if they're too high, impact the total cholesterol, but then also put you at risk for things like pancreatitis as well.
And if you're not fasting, those can be markedly abnormal in terms of doing your blood work.
Yeah.
Just jumping back to LDL, Jeanette's wondering, any natural recommendations for lowering? Does that go back to what you said about?
Great question, Jeanette. Yeah, we have this conversation. We are huge advocates. So things that raise, dietary things that, high-fat foods. So red meat, kind of high-fat animal proteins.
Delicious soft cheeses.
Yes. So when I tell my patients, I've kind of just boiled this down to what can I do? I really ask them, how much cheese do you eat?
Yeah.
And I hope we don't have a big dairy contingency watching the show, but if I had to come down to...
We're big in Wisconsin.
To one simple recommendation in terms of people who start going, how much cheese and dairy are you eating? Other than taste, I don't have a lot of redeeming things to say about cheese, because it really drops cholesterol. So, lowering cheese, lowering high fat. Not many people are eating a lot of fast food or fried food or things like that. But if you are, knock it off, because that's easy. But they're not, So, other things, foods high in fiber lower cholesterol. So steel cut oatmeal, really great, lowers cholesterol. Metamucil, believe it or not, it's a supplement over the shelves, which is one of my favorite things to recommend people. It's a fiber that we don't absorb, depending on your medical conditions. It's almost safe for most people. It's good for your bowels. It lowers cholesterol because it traps food in the colon and helps prevent some of the absorption from it.
It can lower blood sugar as well.
It can lower blood sugar and stabilize blood sugar. So, and then there are a number more strict diets that lower cholesterol. A lot of plant-based diets, people are probably sick and tired of hearing me talking about it, but they significantly lower cholesterol. Removing animal proteins and animal from your diet.
Yeah. Lowering triglycerides, alcohol has a big impact on triglyceride levels, as well as fried foods and even carbohydrates as well.
Yes.
Yeah. So great question, Jeanette.
We have one question in the queue from Nancy, and it's on diabetes, which I think we're about to jump to. So I'll save the question to the end.
We can.
So just finishing up on cholesterol. Yeah. So if people can't control it via their diet, and some people can't. Sometimes there's a hereditary component. They are thin. They are eating really well. They are eating clean.
Exercising.
Yeah. Or people are, we're honest with them, if you're not going to, it's okay. You know what I mean? Because we have things to help here. You know what I mean? So really, there are a number of medications that have been on the market for a really long time that have really, really, really good evidence that they have lowered the risk of heart disease, lowered the risk of death. You've heard of them. They're Lipitor, they're Crestors, they're Zocors. They are almost all generic. They are all actually generic now. They're inexpensive and safe, and they They work right away. They lower cholesterol. Usually within a couple of weeks, we do repeat blood tests and see they are exceedingly safe, and they have to be monitored. Some people do not tolerate them, but some of the medications, because they're newer, they can take them. You can stretch them out, like Lipitor and Crestor. You can take every other day or even a couple times a week to get some benefits. So there's a lot of options. And you're not committed to those drugs either. Like some people are saying, like, oh, do I have to be on this for the rest of my life? And we say, no, just start now to lower your risk, and then we can work on the changes. You know what I mean? And then in 3 months, if you lose weight, change your diet. Let's take it away, recheck.
And see what happens. Yeah. Great. So moving on to diabetes, kind of a huge topic that we see every single day. I would say most commonly, even today, talking about the new onset type 2 diabetic patients. So there's type 1 diabetes and then type 2 diabetes, which tends to happen, later in life, kind of related more towards, being overweight and insulin sensitivity and a whole host of other lifestyle factors. Whereas the type 1 diabetes is the genetic kind of form, even though type 2 does have genetic component as well. So again, a lot of times we pick up type 2 diabetes, new onset, with routine screening labs. Sometimes people will come in complaining of, I'm really thirsty, I'm really fatigued, I've been urinating a lot, I'm hungry, and seem also to be losing weight as well. So those are some kind of red flag complaints. Which do you see those commonly, or is it mostly on kind of routine screening?
I think it's a bit of both. The diabetes burden in the Southcoast community is really high. We have actually one of the highest, if not perhaps the highest rate of diabetes in the state. So it's a real disease. There's a strong, for the type 2 diabetes I kind of talked about, hereditary component. So and people who are at risk for diabetes are if you're overweight, if you're kind of above the age of 40, if you have known high cholesterol, you're not that active. So things that people present, thirsty and urinating a lot. That's because when your sugars get too high, they overwhelm your kidneys and they make you urinate a lot, and then you get thirsty. So that's one of those symptoms. Oftentimes, another thing that people have that they're not sure what's going on is they get a rash. They get this kind of dark ring around their neck or actually in their armpits, and it's a skin changes that are associated with elevated blood sugars. It's called acanthus nigricans. It's a word that no one needs to remember. I just wanted to prove that I could still remember it. And so that happens as well. Or people are getting sick, or they have a wound that's not healing because it affects their healing. But Hannah's correct in the sense that a lot of it is asymptomatic. But we just saw a patient this week who he knew something was up. He's like, doc, I've been urinating more. I'm thirsty. I'm worried about my blood sugars. And sure enough, we checked, and he has kind of diabetes based on his blood level.
Right.
So,
so the question, and again, this kind of harkens back to every with high blood pressure, high cholesterol, with type 2 diabetes. There is a role for similar lifestyle changes to kind of impact those numbers that we monitor. Again, increasing exercise, decreasing weight, dietary changes, not smoking won't necessarily reverse your diabetes, but certainly reverse some of the risks that come along with it. So again, those are the initial changes that we ask people to make, and then some of the really common medications that we tend to start people on, in the absence of any kind of contraindication. Metformin is what we go for first, and again, like you said, tried and true, been around forever. I'd like to take it.
Yeah.
Preemptively, there's a whole lot of benefits there. And then from there, combined with those lifestyle changes, we periodically recheck, the blood sugar levels, and then can add on additional medications if needed. We get,
diabetes, high cholesterol, high blood pressure, disease. Why do we worry about it if I can't feel it? If I feel fine, most diabetics are not thirsty. So why do you worry about your diabetes? Why should you be checked to make sure you don't have it? If you do have it, why do you want to make sure it's under control? It can affect a host of things. It can affect your eyes and affect your vision. It can affect your kidney function. Diabetes, I believe, is the leading cause of dialysis in this country, followed by high blood pressure. I was just talking to one of our, Dr. Sagar Patel, a nephrologist, because the elevated blood sugars just wear your kidneys down. Other for some reason, diabetes raises your risk of heart disease. So you have a significantly higher risk of developing a heart attack with elevating your blood sugar. So you want to manage it. So it's important. And so that's why it's kind of really why we care so much about diabetes, and it can affect circulation. People, you have a wound that doesn't heal well, then it can lead to an amputation, and then one thing after another. So it can be kind of a cascade of problems if not treated. However, if it is really treated effectively, it can be fine. Mm-hmm. People live long lives really well with diabetes, whether they have their whether they need insulin or not, or whether it's type 1 or type 2 diabetes. It's manageable, and we are lucky to again talk about what a great team of people we have. We have diabetic educators in our offices, and at Southcoast we have pharmacists available to work with people. We have nutritionists. We have endocrinologists for the really advanced cases who we can rely on. So lots of great options.
So Nancy has a question about the types of medications for type 2 diabetes. She's a 65-year-old female. She's already on metformin, Invokana, Januvia, and Tresiba, which are kind of several different classes of medications.
Before I was going to say thank you for taking that question.
Because you took the last one for the
I would have had a lot of angry pharmaceutical companies calling me after I butchered the names of all of those drugs. So thank you for taking that.
Well, thank you, Nancy, for the question. It is something we see commonly. Without kind of knowing your full medical history and where your blood sugars are at and your A1C, you're on an excellent kind of regimen of medication right now. The one couple things I see missing perhaps maybe is whether or not insulin may play a role at some point in this. Is she on?
She's on Tresiba. I'm sorry.
She's on Tresiba. Yeah.
A glipizide type medication is the only thing that I see missing that just from face value there. Again,
metformin, is she on metformin?
Yeah.
Good.
Yeah.
Then kind of a little bit broader spectrum on the realm, and depending on which type of diabetes you have, but there's also the bariatric surgery. So this is I don't know Nancy's story, but if there are people who have diabetes driven by excessive weight, there's really good evidence now that actually some of the bariatric procedures reverse and treat diabetes very effectively if medications cannot do it any longer. So that's also something, an option.
Good. And getting back to kind of another general question from Kathy asking about what vitamins she should take daily. And I think we're going to do a whole show on kind of vitamins and supplements and over-the-counter remedies. And it was funny, we were talking about that before the show too.
Really common question we get. So I think we talked about the first things, depending on what you're eating and how you're eating. Mm-hmm. If you are a healthy, woman who doesn't have any major nutritional deficiencies or man, you know what I mean? And we like to say the best way to get it is through your diet. So if you eat a variety of colors in your diet, it's good. You probably don't need a vitamin.
It's unlikely.
Yeah, I really don't think you need a vitamin.
Right.
Absolutely. And there's mixed studies on it. Right. They're not dangerous vitamins. So some people say, should I take a multivitamin or not? And just the question is, it's never dangerous. So it's fine to take it, but you may not need it, And for some people, they disagree with. The only vitamin actually I can tolerate is my children's Flintstone vitamin. I eat them because I'm a vegan for the most part. So that's fine. Other things, depending on your age, calcium and vitamin D, postmenopausal women, they should get 1,200 milligrams of calcium from all sources and 800 of vitamin D in their diet. Hannah, am I missing anything else?
No, that would be, so the only time that I really recommend any type of supplements is the calcium or vitamin D for bone health in postmenopausal women.
If you're
and men as well too.
Yep. And if you are a vegan or following a pretty strict plant-based diet and you're not, you should have your B12 level checked. You often need a B12 supplement.
Sometimes I'll recommend magnesium kind of at a low dose, 400 milligrams a couple times a day if people are having cramps. I usually do like to check a magnesium level first because it's certainly a high magnesium level can be harmful to your heart.
Migraine headaches, I think there's some anecdotal data that I've seen in working with neurologists. I recommend people B-complex vitamin magnesium actually helps prevent migraine headaches for a lot of people, so that there's a good route for that. Yeah.
More to come on that. I think we'll have to figure out an interesting show for supplements and kind of some recommendations there. We do have another question from Tony asking about our thoughts on taking Miralax long term. Is it harmful or not? So this is kind of moving away from into the GI realm of things.
So bowel is super common question in constipation.
Yeah, constipation and talking about primary care complaints is something that we see very regularly. So in thinking about kind of regulating bowels and different types of medications to help you move your bowels, there's different classes. So there's medications that kind of add fiber to the colon, and that would be like the Metamucil, and add a little bit of bulk to the actual stool, and actually can actually stimulate some of the nerves within the colon to kind of get moving along. Other classes of medications, and I believe Miralax is one that just actually draws water into the colon, and kind of softens the stool and kind of makes it a little bit easier to go. There are stool softeners as well, such as Colace, which is kind of, if you've ever accidentally popped one open, it's kind of an oily substance, which again just makes stool a little bit easier to pass. And then there's the stimulant medications like a Senecot, which actually kind of stimulate your bowels and make you go. And then there's other types of medications that use difference in electrolytes, so your mag citrate,
milk of
magnesia, that kind of again stimulate the bowels to kind of move. For Miralax, I think it's very safe. I oftentimes will start recommending a cap full of Miralax as kind of the first step in trying to get someone's bowels moving regularly, or even to just kind of calm things down in general. What's your
I think so too. It's one of the
recommendation there?
it's absolutely one of the more common ones. With these situations, that depending on your age and where you are, if you at some point, I think it's worth investigating the source of your constipation, why you're not moving your bowels. There's a number of things that are safe, and just people have different bowel regimens. There are certain medications that can complicate it, but there's some other worrisome things too that in terms of making sure colon cancer screening, colonoscopies if it's been done, and so I think Miralax is, like Hannah said, exceedingly safe to stay on.
And it's used in pediatrics really frequently too.
So, but it also just making sure that if you've not had your constipation evaluated, just to make sure you do.
Okay. Any other common GI complaints that you see?
Heartburn.
Heartburn, yeah.
I think, really common in terms of what we see every day. Often people are very aware that heartburn is happening. That is not a silent symptom.
Not a silent,
whether it's coughing, which they may not know is heartburn, but it is, and this burning sensation. People, what is it? It's like, so it's your stomach acid kind of going up into your esophagus, which goes right behind your heart. It can feel like a heart attack. It feels like your chest is on fire.
It can feel like the top of your stomach is burning. Yeah.
Really common things that can cause it, tomato sauce, onions, caffeine, chocolate, a host of things. Usually happens 10 to 20 minutes after people eat,
and again, kind of talking about things initially that we recommend for treating heartburn. So basically what happens is there's a little sphincter at the top of your stomach, and depending on the pressure kind of gradient within the stomach, it kind of forces that valve open and can allow some of the acid that's meant to kind of break down your food and release all the nutrients for your body to absorb in the colon, allows that acid to kind of reflux up into your esophagus, and that's when you get those symptoms. So things that you can do to lower your esophageal, kind of that pressure in the sphincter, and kind of without medication, smoking, weight loss.
Not smoking.
No,
Smoking doesn't
smoking doesn't
help it. Just want to be clear on that.
Teamwork, yeah. So not smoking, weight loss. Sometimes there's a role for elevating the head of the bed a little bit. There is a little less data for actual kind of global elimination of spicy foods, but if you certainly have a trigger, if that tomato sauce makes you, experience heartburn, that would be something to kind of cut out first. And then kind of first line over-the-counter medications that we talked about before are the, histamine 2 receptor blockers, which are safe. That would be like your Zantac and your Pepcid.
Tums is really effective.
Tums is good too. That's an antacid.
When to worry,
yeah.
that, is also too. So heartburn's okay, except for certain scenarios we worry about. So if you have trouble getting food down, so food is getting stuck, that actually is worrisome, and you should be, checked out. And if it hurts, it shouldn't hurt when we swallow it. You know what I mean? So food should be going down fine. If you are losing weight unintentionally, that's never a good sign associated with heartburn. You worry about an ulcer, God forbid. Pain in the stomach that gets better or worse with food, that can be a sign of, depending on where the ulcer is in the stomach, food can make it better or worse. And God forbid if you see blood in your stool, if your stool will become are changing color, kind of darky, kind of coffee,
or if
kind
you
of
vomit blood.
Yeah, or if you vomit blood, which.
Yeah. Please don't ignore that.
No, don't. So those are worth getting checked out. Most people don't have those symptoms.
Yeah, so the other concern with untreated acid reflux into the esophagus is that over long term it can cause kind of changes of the actual tissue in your esophagus, and it's called Barrett's esophagus, and it's actually a precancerous change that we see. So that's the concern. It's not just heartburn. So if it goes untreated, we do kind of take a stepwise approach in terms of adding medications and even getting a look down with an endoscopy through one of our wonderful GI doctors to look for any changes there.
Really common question, I'm not sure if you're getting a lot, which is good, is people are questioning the safety of Nexium, Prilosec, and these PPI type medications that have been a game changer in terms of relieving heartburn symptoms for people, lowering risk of esophageal damages and preventing cancer. But we've learned as medications have been out over a period of time, there's really no free lunch, right? So yes, these type of medications we know can affect how people absorb calcium. They can increase our risk of certain infections and pneumonia. They may or may not affect some cognitive function later on.
And bone health too.
And bone health and like osteoporosis. So what we we tell patients is that you want to be on the least potent medication possible. So number one bad thing is to have uncontrolled heartburn, like Hannah just talked about, because it can lead to esophageal changes, possibly esophageal cancer. So not treating your heartburn is not a good strategy. But you want to use the least potent medication as possible. So whether it's a Pepcid or a Zantac first, and if that doesn't work, going up to a Nexium, Prilosec, which are also over the counter, maybe getting checked out by a gastroenterologist. Again, and then making changes, whether you lose weight, change your diet, kind of backing off these medications if it's appropriate to see if you still need them. Because sometimes after a while you don't.
Right.
So giving a medication holiday is really important. So.
And by my recommendation for people in kind of addressing the kind of newly known side effects of the omeprazole, the proton pump inhibitor medications, is that while yes, there certainly can be negative side effects if your acid reflux is not well controlled without that medication, the risk of kind of those precancerous changes in your esophagus outweighs the risk of the side effects of the medication. So in that case, it would be appropriate to stay on them kind of longer term.
Awesome.
Yeah.
Any questions in the queue?
No, we're all caught up. I know we're getting close to the end of the hour here. I don't know if I know we promised we talk a little bit about availability and other docs.
Just right before that, so one of the things we're trying to kind of reinforce with patients this year, people who haven't watched, there are 4 behaviors that the CDC says that will prevent or cause most of the disease in this country. And so it's smoking, alcohol, drinking more than really 1 or 2 drinks a day is not good. Inactivity, so we should move for 20 to 30 minutes most days a week, whether even as simple as walking, and being overweight or obese. They drive cancer, heart disease, diabetes, lung disease, the things we're talking about. So quitting smoking or not starting smoking, limiting your alcohol intake, finding time to exercise, as simple as walking 30 to 40 minutes most days of the week, and keeping your weight down will fundamentally prevent most of the diseases in this country. I will add to that looking at population studies from around the world, the people who we want to be like when we're 90, if we want to live to 90, 95 and live well, enjoy our friends, families, work, play, do what we want to do, those people get most of their nutrition from like a plant-based diet. I'm a really big proponent. They do eat proteins, meat, fish, but 70 to 80% of the calories are from vegetables. So really having, you don't have to be a vegetarian or a vegan, but making sure you get a significant number of your calories from veggies is a good thing in your plate. And I think the goal is, like we talked about nutritionists, 50% of your plate kind of veggies, 25% of your plate, maybe a protein, and 25% of starch. How to find a doctor. The Find the Doc website on southcoast.org has primary care doctors listed who are accepting new patients. You can make appointments electronically, right, Peter? Like just book right into them?
That's right, yep. If you go onto the website, there's a small button that says basically make an appointment now next to those primary care doctors who have availability, nice and easy. You're not guessing which ones are accepting new patients and which ones are not.
Yeah. Great.
And can I just add, there's I know there's Dr. Kevin Gendro was logged on earlier watching. He's been a guest on the show. He's someone that I think is accepting new patients currently, and he's a local Fall River guy as well. So
Tessa Draper practicing in Fall River now.
Theo Addo.
Dr. Theo Addo is in Dartmouth. Yep. And so we have a great team. Yeah. And so, kind of mixed emotions. Peter, last show.
It is, yes, yeah. So I'm gonna miss you guys, but I feel like it is in good hands, and I look forward to watching on the other side.
Yeah,
we'll look for your comments.
Yes, I'll be generous with them.
Peter, thank you for creating, along with Josh, the idea for this program. It was your idea, and it's been amazing, and I really we appreciate you inviting us to participate in it, and I mean, so many people have been, really just been so grateful for the show, and so it's a game changer what you did. So we will work hard to make sure
this show. I mean, it started as a small seed, but if you and Hannah hadn't come on board and brought the energy and knowledge that you bring, it would wouldn't have become what it has become today. So
also really nice to culminate. Like, how much weight have you lost? Let's end on how good you look. How much weight have you lost?
Thanks.
Right?
Yeah, doing the OptiFast diet, which is available at Southcoast Health. I'm about 25 pounds, and I feel really good.
You need new clothes.
I'm transitioning off that now, and I probably could have reported a higher number, but I had reverted. I really fell off the wagon over Easter weekend. Ate pretty much anything that was in my path, and so. But thank you. It's a great program. Again, it's been pretty painless to lose 25 pounds, and I think that it's pretty hard to say that on a lot of other diets. So again, it's OptiFast. You can find that information on the southcoast.org website by searching for it.
Yeah.
Great.
And Kathy and Tony are begging you not to go, but
I'm going to miss so many people here, and it's definitely bittersweet. And thank you guys for acknowledging this, and I'm going to miss it. And
we wish you well.
But I won't be a stranger. Thank you. Thank you.
Thank you, everyone, for engaging, sending questions in, really making the show the success that it is. Please forward thoughts, questions, comments, ideas for guests. We would like to, this is your show, and we're here to help kind of, spread the information that we think is appropriate for you and also get your questions answered. Thank you, Josh, our producer, as always, for running a great show. And we will see you next week. Stay healthy, South Coast.
By the time I graduated high school, I think I was between 275 and 300. I had to buy my dress clothes at the Big and Tall store. Enough is enough. Southcoast Health gave me the tools, and here I am, with my health. And I was a 46 going into a 48, and now I'm a 30-inch waist. I'm living proof to show if you put the work in on anything that you can get what you want. Take impossible, throw it out of your vocabulary.
I had 2 blockages. I had to have a catheterization, and told me that we needed to see a surgeon as soon as possible. Dr. G made me feel like I was his only person that he ever did surgery on. You don't have to go to Boston. You can come right here to Southcoast and get the best treatment. I said to him, Dr. G, I guess I'm going to fall in love with you. He says, I know I'm going to touch your heart.